Hi, well, welcome everyone. Thank you all so much for joining us. My name is Mehlaka Samdani. I am Director of Critical Connections. It's an organization here in Western Massachusetts that puts together events on issues related to American Muslims and other targeted communities. However, with the onset of COVID-19, we have decided to suspend all regular programming and instead are putting together online events that cover the various dimensions of this pandemic and all the communities that it is affecting. So today our event, Protecting Our Protectors, is the second in our series. And we're going to talk about the conditions under the very grave and heartbreaking conditions under which our healthcare personnel, nurses, doctors, other staff members are currently operating while they treat patients with COVID-19. And we're also going to talk about how we as a community can provide help and support to them at this very, very critical time. To help us do that and understand all the dynamics at play, we are very fortunate to be joined by Christine Pontus, who is a registered nurse and also the Associate Director of the Health and Safety Department at the Massachusetts Nurses Association. And with her is Dr. Kavanagh, who is joining us from Kentucky and is a retired physician and is also the founder of Health Watch USA. So thank you both so much for joining us.
Well, thank you very much.
So before we begin, just a couple of things. First, let me just describe what the structure of our program is going to be today. For the next few minutes, I am going to ask both our speakers a series of questions. Again, this is just meant to start the conversation. These aren't exhaustive questions at all surrounding our topic. And we're hoping that right after that, we are going to sort of open it up for a Q&A session. Christine and Dr. Kavanagh, thank you so much for joining us. Christine, let me begin with you. You know, every day we hear about horror stories and we hear about nurses and doctors and staff members across the country, especially in New York, who show up to work every single day, very heroically treating patients with COVID-19, but they themselves, these healthcare professionals, do not have adequate PPE or protective gear available to them. I have heard of doctors who have bought their own eye shields. I have heard of doctors who are using gowns and masks over multiple shifts. Just last week, 2 nurses in New York passed away, and there are more than 200 healthcare workers who have currently tested positive there. Christine, can you tell us about the situation here in Massachusetts? Do our healthcare personnel have adequate PPE? Is there more coming? What are you hearing?
We're hearing, for the most part, that the hospitals are rationing the PPE they do have, meaning we at MNA are advocating for an N95. That means we are asking for protection of at least an N95, which filters out 95% of the particles, and also that it be a biological mask, meaning it would not only take out dust in dirt, but virus and bacteria. Unfortunately, the N95s that are generally made in the country, which are a small, medium, and large, which can be fitted what they call a fit test in the hospital, is not currently available in the numbers that we will need when the surge comes. Kevin and I will discuss that, what the numbers are, but just for the next few minutes, what we understand is that they are rationing what they have because they're predicting, and rightfully so, as we know from the other countries, that there will be many more people who will test positive, and those snugly fit N95s they feel they will need for the positive patients. What we at MNA believe is that we should be protecting the nurses and the public now with such snugly fit N95s. Why? Because we believe that the virus is being spread as we speak, with people coming in and the nurses not being protected. So it's rather a catch-22. Because the supply isn't there, and we're trying to protect the nurses with what we have, we in fact are not protecting them. And try to protect them further when we know there's going to be more positive patients. So, and I think Kevin will agree with me. So we're seeing a lot of rationing already. We're seeing a lot of actions not based on science. we're seeing people making it up as they're going along because the CDC is shifting and changing the recommendations daily. So there's much confusion. And we're asking for engineering controls in the hospital along with the PPE. We're asking for nurses to have not only PPE, but plans to let them work like an 8-hour shift as opposed to a 12-hour shift. They're going to be exhausted. We're looking for all kinds of accommodations. So
Yes.
that's the beginning of it, yes.
Sure. And so we're going to talk about the extra shifts that nurses and doctors are being asked to sort of, take as well. But before we do that, let's sort of talk about the PPE. And Dr. Kavanagh, would you like to add anything to what Christine has said and what's happening in your part of the country?
He's on mute.
There you go.
There we go. Unmute myself. I have to learn the new technology.
Exactly.
In my part of the country, we are not in a huge surge. We're just starting to acquire cases. However, we're still under shortage of PPE. Why is that? Because it's hard to purchase PPE since it's being sucked up and used by other hotspot areas. Now, you should also realize that anybody that comes into the ER with the sniffles or whatever is going to have to be met with someone that has PPE on. And this is a huge strain on the supply chain and the system. So if you do not have symptomatology that would require evaluation in the emergency room, please do not go into the emergency room. And if you're thinking of going to any healthcare setting, including the emergency room, call in first. Now, the other problem, and this is a huge problem, that's asymptomatic carriage. It is known now that at least 25% of the cases, possibly more, have been acquired from people who do not know that they are carrying COVID-19. And asymptomatic carriage sometimes is all that person will experience. They get an infection, but no symptoms, but yet they are spreading the virus. Also for people who get infected up to 2 days, also for people who develop symptoms up to 2 days before the symptoms develop, they can be transmitting the virus. So this means that somebody could come in with a stroke, with a suspected heart attack, with a sprained ankle, and they could still be spreading the virus. So in Kentucky, we have one hospital now that is using PPEs or N95s system-wide. Now, it should also be noted, and we'll talk a little bit about this later, that N95s are not a top mask. I think this is really minimum standards. Below that is a surgical mask. But it will only filter out 95% of the particles. Surgical mask. But it will only filter out 95% of the particles. And with a very dangerous virus, you'd want it much higher than that. And that's kind of what we're dealing with. There's also N99 masks, and there's also hoods that have airflow going into tanks or out the back. So there's all sorts of different levels of protection. But the N95 mask is really just the second tier. And to not have these and to not have these stockpiled is really inexcusable. Today, they just announced on CNN that the strategic stockpile is starting to ship out their last shipments of masks. There were in 2009, almost 100 million masks in the strategic stockpile. A significant number of these, close to 65 million to 85 million, were used for the N1H1 epidemic, and they were not replenished. And this then went down to 12 million available, plus another 5 million, which are available but are out of date. So it had very few masks starting out. So there's been a lot of neglect to our infrastructure.
Absolutely. And Dr. Kavanagh, you and Christine keep mentioning the N95 mask, and that's like, just the basic protection that our doctors and our nurses need. And yet there are so many hospitals around the country that have issued appeals for DIY masks, for literally asking communities to make masks. And we have seen so many communities mobilize themselves and come up with homemade masks. Some of them are made of cloth, others are printed out in 3D printers and stuff. What kind of protection do they provide? What are your thoughts on that? Let me ask you first, and then we'll turn to Christine about this.
Well, they're minimal at best. They're probably at the level of the CDC guidelines for when all else fails is to use a bandana or a scarf. I mean, this is what I would expect to be using in a third world country. The DIY masks are somewhat effective in preventing you from spreading the virus to someone else. In other words, if you're an asymptomatic carrier, you want to prevent that from spreading to someone else. But as far as using it in a healthcare setting to prevent you from acquiring the virus, they're probably better than nothing, but I'm not sure how much better. Now, I should add that N95 masks are probably going to be in demand with the public, but unless you really have a gown, goggles, know how to safely put the mask on, take the mask off, the same with gloves, it's probably not going to do a whole lot of added protection. It may actually give you a false sense of security. So I would be very careful of going out and trying to stockpile these. Also, and I think Christine will verify this, they're fairly difficult to breathe through and are quite hot. They're fitted around your nose and mouth, and because they're filtration of very fine particles, there's not much air can get through them, so they are very uncomfortable. And if you look at some pictures of Southeast Asia, you'll see now and then people wearing the N95 masks below their nose and covering their mouth, and well, that's just absolutely ineffective. I mean, that will do nothing. So the best thing to do for the public is wear a DIY mask for now until other masks are available, and stay away from people or stay at home. And staying away from people is at least 6 feet, if not more.
Okay, so you're saying that the public should be wearing some of those masks, the DIY masks, that they do provide some minimal protection to our healthcare workers, but they should also be used by the public itself. Christine, what would you like to add to that?
I like Kevin, would advocate that when a patient comes in, we should be masking them as they enter the hospital. So there are some surgical masks that they're not snugly fit, but they are known to screen 99%. They call the surgical mask 99. So it gives a little more protection in that it's rated. It's better than you make your own. It's better than just cotton or cloth. But studies with your homemade masks actually showed that cotton t-shirt material was best. I read this from one of the scientific journals, and believe it or not, they measured with homemade material which one was the best, and it came out to be like a cotton t-shirt that was, the textile was thick. So to the point of what Kevin was saying, yes, I think we're going to see us as a public more like other countries wearing masks. Right now we're not. It would be, from my understanding of it, it is to keep the person who is possibly asymptomatic from spreading it to someone. So when they come in the hospital, someone's going into a grocery store, gloves and a mask may not be a bad idea right now. It may look silly, but I'll be honest with you, from the precaution perspective, it's not a bad idea.
Great. And has the CDC, are those part of the CDC guidelines, or is that, they're not, right? And that, yeah.
No, they are not.
No.
They are part of the Chinese CDC guidelines, and there are a lot more public health officials that are not associated with the government starting to recommend that. What they are concerned is that in view of the very short or the very small N95 supply for healthcare workers, that if the public starts wearing masks, that's what they will start purchasing. And another problem is that multiple people purchasing the masks are bidding up the price. We do not have a coordinated system. I think that may be another topic you'd want to dwell into at some point.
Great.
So
Kevin and Christine, this is for both of you. I mean, who should be providing our healthcare professionals with this PPE? Who should we as the public be petitioning to get our healthcare personnel the protective gear that they need to combat COVID-19? I mean, is it the state? Is it the federal government? Is it the hospitals? Who should we be calling upon as community members to get our doctors, our nurses, our other staff members the supplies that they need?
Well, the hospital should have a huge stockpile of these from the get-go. That's number one. They've squandered, in my opinion, a lot of resources on things which were not directed toward patients and patient care, and their infrastructure has become pathetically small. And that goes from nurse staffing to supplies to availability of hospital rooms, very little redundancy in the system, even though many of these large systems are extremely profitable. Now, as far as who should get the masks now, I think there's no question that should be a federally coordinated procurement process. I like to give the example of World War II. When the states went to war and soldiers were enlisting from the various states, the states were not responsible for getting their uniform and guns and going out and competitively bid and paying exorbitant prices for that material for them to go to war. That's how you lose a war. And we are in a war at this point, and we definitely need to get a centralized procurement process where we get the material to the states that they need. Now, of very important news is that there is a company which has made and developed a unit that will re-sterilize N95 masks and gowns that are used. Now, this is, of course, not if they're completely splattered with blood, but if you see a patient, they're perfectly clean. Otherwise, to look at, you can re-sterilize them and they can be reused instead of trying to somehow figure out how to put a contaminated mask on. And I think Christine will agree with me that when you ask me how to put a contaminated mask on, or what about DIY masks and which is best and how to make them and all this, this is something I'm no more an expert on than anybody in the audience. You're not taught this in medical school. No one ever could have envisioned that the United States would have been in this situation. I mean, this is like a third world country. Maybe if you have experience with the Peace Corps, you would know these things, but certainly not a doctor that's been trained at a top institution. This is very, very discouraging to see our healthcare system in this position.
Absolutely. And I think Governor Cuomo has repeatedly been asking for a sort of centrally, the central government, the federal government sort of procuring all of this equipment together so that the states don't have to bid against one another. Christine, would you like to add something to what Dr. Kavanagh just said?
Yes, I'll go back to the basic premise that, working for a hospital and hospitals have an obligation, as Kevin was saying, to provide this. And I think we really need to look at this so we learn from it so it won't happen again. What is going on? We understand the business model is lean, and like Kevin said, there's nothing saved, there's nothing in stock. But even more importantly, after the hospitals haven't done their duty, where is the due diligence of the government? Where is the due diligence of coming in, like in the past FEMA? I'm old enough to remember that when there were tragedies that the government came in very effectively and helped people. Katrina was the last time I can actually say that it was a shift with Katrina. We stopped seeing the government come in and actually be effective. That's, the knowledge and the resources were not there. Prior to that, we could always depend on them. So I think we need to reset and go back and look at what's been dismantled as a country, as a public health system, as a health care system, and look at where the money's going and why it's not there. Okay.
It's a very important point. And talking about hospitals and what their responsibility is, we've been hearing a lot of reports about considerable tension between hospital administrators and healthcare professionals. Sure. With hospitals and administrators sort of really calling on doctors and nurses and other staff members to work extra shifts, whether or not they have adequate PPE. If they get sick, they're still required to come in and tend to patients. So what can you tell us, about that and what is sort of going on with that? And we've also heard of hospitals sort of gagging their healthcare personnel in sort of talking about this to journalists and not allowing their workers, their medical workers, to be sort of speaking to the media about the conditions that they are facing.
Well, it's interesting you say that, because just yesterday I spoke with an infectious disease doctor, a physician, she is a female, and she told me that a colleague of hers was told not to say anything when he spoke up about PPE. And I guess he did go to the press, and he did, in fact, and Kevin will speak to this later, he did in fact jeopardize his job. So the nurses have been dealing with this bullying for a while, and now the physicians are seeing it. And it's interesting because the lack of science to back the decisions that are being made. And in one of our hospitals in Massachusetts, the nurses actually protested and stood up for patients' rights. And through the work of Mass Nurses Association, they were able to sustain what they felt was a nursing principle of care. So as Kevin will speak to later on, we need to keep our principles of nursing, of medicine, of science, because if we let all this go away and it's erased from the world, we're going to forget what good care is and what the proper way to do things are. When there's a war, the first thing that gets burnt is the books, and the intellectuals get wiped out, and the lawyers are gone, and the teachers are taken away. So it's kind of a war in a sense where we're seeing things dumbing down. It's frightening. And, you know, by this confusion and things changing on a daily basis, people who went into the profession to do good are now being ostracized for wanting to do what they know is best.
Great, thank you. Dr. Kavanagh?
Yeah, I think that what they're doing right now is giving recommendations based upon being in crisis mode. They're not giving recommendations based upon keeping people necessarily safe, but what's the best way?
When you say
Well, the CDC or the government, you know, the recommendations that you're hearing, it can be at multiple levels, but they're giving recommendations based upon what they have and how can we best give patient care with what's available. Unfortunately, what's available is so little and so inadequate that the recommendations given are just plain not safe. And that's another reason why you should not go to the hospital unless you call ahead and you are very sick. In China, there was one paper that 51% of the infections were traced back to a single facility. Now, this is just in one area, of course. So there is a problem. And this also gives rise to the problem of collateral damage. You're going to have people with heart attacks who don't come in, people with strokes who either don't come in or come in and get COVID-19 and then have a fatal outcome instead of a outcome which would have been survivable.
You know, sort of another question, and this is one of our final questions before we sort of open it up to our audience.
Okay.
Christine, so I mean, as you know, Dr. Kavanagh was just mentioning, there's so many other people, you know, who need care but will not be given priority because of this crisis that we find ourselves in. And we all know how overwhelmed our healthcare system is at this point, and priority, of course, will be given to people who, you know, might have COVID-19.
Right.
So my question is, what can we as community members do for our own health so as not to inundate and overwhelm the healthcare system further? You know, what is it, what kinds of precautions other than washing hands and, you know, social distancing can we be taking in order to protect ourselves and those around us?
Okay, so first of all, during high touch areas, we know you're saying, yes, washing hands, but also wash like the refrigerator door, your door to your front door. If you have multiple doors, multiple doorknobs. Anything that gets frequently touched, when you go food shopping, leave it in your garage or in your, on your porch, wipe down if something has to come in like a bottle of orange juice. We actually keep gloves on and wipe that down with a sanitizer or alcohol-based material, things that need to be refrigerated. So those are a few ways of bringing things into the house that you can keep yourself protected. As far as keeping your own mental health and your own physical, make sure you get exercise and take vitamins. Vitamin D is a very good immune system builder and helps maintain your immunity. Also, vitamin D has most recently, I'm not a physician, but can tell you, if you look it up, that most recently the research has shown that vitamin D actually does target the upper respiratory and the lung. So there's an added benefit to taking that along with your multiple vitamin. Okay, you can check with your doctor if you want. I'm not saying go take huge doses of it, but you can take it from the store, the pharmacy, and get yourself some vitamin D. It's been well documented. It's a good immune system builder. So this has been all over the news, and you can look it up. But you say, what can you do to protect yourself? Build your immune system up. Eat well. Take some time off from the TV from COVID-19 and laugh. Laughing is a good thing. Make a joke. Swear if you have to. Do what you got to do. But make sure you're taking care of your body and your mind, because your best fight for this is resiliency. It's very hard because people are dying and we're human beings, and we become depressed. We don't want to get depressed where our immune system is affected. You need people who are dependent on you. So eat well, sleep well, joke around if you can, and know that this will pass.
Specified this. They're like, yeah, you can go out, you can do this, you can do that. But I'm wondering, I mean, do you think it's now safe? I mean, given the numbers that we're anticipating, for us to go for a walk around the block, or is it safer just to sort of stay by our, within the vicinity of our own homes, like the perimeter of it?
It's a good question, because I take a bike ride when I can in my neighborhood. There's no one out there. I'm out on my bike like today. Rain, I'll go out there when no one's out there, and I'll put a slicker on, and I'm riding, and it's
also,
a little drizzly. I'll walk the dog. So
social media,
I try to go out in the evening when there's not people around.
I'm from Pakistan.
I can't say from a society whether we all should not go out.
And they have very strict
in my neighborhood, it's not that
measures in place.
I'm not in New York. I'm not in a densely packed area. So
and my
I
question to
go
you
out
is, I
and
mean,
there's not a
again,
lot of
CDC
people. I wave at
guidelines have
people, and
not.
there's social distance that can be kept. In New York, when you go on a train, or when I go into Boston, for example, if I was on the Red Line, that's more of a challenge. But in my neighborhood, so I think the assessment needs to be made about where you live and what you can do, and maybe go out in the evening, or in an area that's not so crowded.
Great. Thank you so much for that. Thank you so much for that, Christine. I think we're now going to open it up. We have lots of questions.
Yes.
Okay, great. So I'm a healthcare professional in North Carolina. I've been a nurse for decades, but I now work in healthcare IT, and I build in the electronic medical record. And in North Carolina, we're scrambling to figure out what we need to do, and it changes several times a day what we need to do. It's just really, really hard. I'm happy to take any questions or offer my opinion, but our state is now listing our ICU beds and our ventilator resources with our state health department, which I think people need to know. It turns out that we have 600 people on ventilators right now that are not COVID-19 related, because there are a lot of reasons why people need to have those resources. Do
you have a question?
I don't have a question. I'm just kind
of. I'm glad you're here, and we want to hear. There's some other medical professionals here. There's one with a question right now, I think. So we're going to go to him, Dr. Fahim Kazi. So we'll go to him next. Thank you, Amy. Can you unmute yourself and turn on your video and join us, Fahim Kazi?
Hi. So yeah, let me briefly introduce myself. My name is Dr. Kazi, Fahim Kazi. I belong to a very large nursing home group. I'm a geriatrician by specialty, and I belong to a large nursing home group in Western Mass area. So I just want to, basically it's not a question, just an observation, and just want to give you a perspective from a nurse. We are hearing a lot about the hospital related issues vis-a-vis COVID-19. But what's happening, there is a lot which is happening in the nursing home also, which is completely unattended and in almost in a shadow. So a lot of patients are still being cared in the nursing homes, and the nurses have, as Dr. Kavanagh mentioned, that nurses do not even have, forget about the respirator or what we call N95. They have basic masks or homemade masks, and they are actively going in to people who are symptomatic and COVID-19 positive. So very sad state of affairs, and there have already been multiple outbreaks which have happened in nursing homes. Any average nursing home, as you guys know, is 100 to 200 bed facility, and so it's a very worrisome state of affairs. What's happening in a nursing home, which is not getting due attention.
Do you have any question for any of the other speakers, maybe?
No,
Like
no,
the nurses.
just an observation.
So
Just want to
Christine
make a-
is with the, well, I'm thinking she's with the Mass Nurses Association. So I would have questions about how the Nurses Association is dealing with these issues as a policy, you know, as a fight on the whole statewide level. Can you speak to that?
Sure, but specifically, I'll speak to this physician's concern. I spoke to a woman yesterday whose husband worked for the visiting nurses, and she said that company was a company did not have any PPE for her husband. So as this physician, Dr. Kazi is saying, this is concerned because this is an at-risk group, and the workers are not protected. So absolutely, it's a concern because then they come into the hospital, or the workers that go into these nursing homes go back into the society, and they're vectors. So absolutely, it's a real concern. Yes.
Just
Dr.
one more
Kazi, do you
comment
want to
that,
respond? Yeah.
you know, I can tell you that, you know, I've been seeing, you know, I've seen many COVID-19 patients in the nursing home. I have one N95 mask, which a friend of mine gave me, and I've been wearing for the last 7 days. I've been bleaching it and all that. That's all I have. And it's you know, so it's very, you know, it's very scary picture in the nursing home arena.
Yeah, and let me just add that's one of the reasons why I am so scared that the optimistic projections of 100 to 240,000 deaths with excellent social distancing may be way too low and just plain not achievable. No one was trained in medical school on how to do third world medicine like this. You would have to be in a Peace Corps. No one knows how to make a good do-it-yourself mask. We really do need to have some better guidance, and as said, the guidance is changing daily. That's because as our supplies are being depleted, people are coming up with new rules trying to make the best situation out of a terrible situation where you do not have adequate protective equipment, you do not have adequate staffing, and it is a situation right now that I think is just intolerable. The United States is going to go through an extremely rough 2 weeks. I think everybody can agree with that.
Absolutely, absolutely.
Let's hear from Lee Tilson. Lee, are you still here? You have a question?
I am. Yeah, I've done a lot of different things in my life, including taking on City Hall, doing community organizing, doing Saul Alinsky organizing, getting involved in state and city politics in Detroit. And the thing that bothers me the most is that we as a society are using far less than 1% of our available resources to address this problem. In particular, the politicians that I know that are very effective problem solvers, people like former Senator Carl Levin, absolutely brilliant. And so many other people don't have the medical expertise that are needed or the medical information for him or other people like him to step forward. And one of the concerns I guess I have is, what can the medical community do to try and identify some specific strategies that if in fact you had a huge movement, maybe all the unions in the country, maybe community organizations, you know, whatever other organizations there are, churches, whatever, if somebody could identify the companies that could manufacture more N95 masks, if somebody could identify other PPE equipment that would be helpful, and then could we connect somehow with these political leaders at the community, state, and national levels to say, hey, we're going to solve this problem, whether or not number 45 does or not, but we got to figure out a way to get more PPE equipment manufactured, and let's sit down and let's do it. We're not doing it.
Does one of the speakers?
Yeah, I
Great
think
question.
procurement is very important, Lee. There's no question about that. But it does have to be done at a federal level. The National, Defense Act should have been implemented many, many months ago to start this mandate of manufacturing of masks. That's going to take federal action. It can't take state and local action, getting a factory to do it. We really do need centralized action. Most of the medical staff right now are just succumbing with an overload of patients. They don't have enough staff. They're in crisis mode right now.
Well, I agree with you, but let me put this to you. Let's suppose that while I agree, I'd like to see it done at a national level. Why can't we get organized and put the pressure on at the national level? Why can't we be putting the pressure on the leaders in the Senate and the House and the governors, and be forcefully putting political pressure on them to solve the problem and come up with specific strategies? Say, Mr. President, why don't you do X? And then we all get together behind it. It's not just,
Well, Lee, unfortunately, it's not going to be gathering behind anything, I'm afraid. I think the political pressure is going to be the body counts, the refrigerated trucks outside of the hospitals, et cetera. The healthcare staff are just flooded. It is real crisis mode. I think it's going to be absolutely an ordeal that you cannot imagine the next 2 weeks.
It's happening. It's happening to us. Yes. Okay. So, I think the point here is that it's really happening to us so fast that we're not able to respond to it.
Can I speak to it, Sanford?
Yes. Go ahead.
Okay.
Yes.
So we're taking some action at M&A. We have actually, like Kevin said, procurement is really where it's at. And the governor of Massachusetts himself has been trying to get supplies in, and they have been getting some from the stockpile. As a nurses association, we've gotten involved with someone trying in making masks. We actually have a pilot right now in one of our hospitals. So, and I know on Hopkins, for example, they're making their own face masks. So there are individual efforts happening. The face mask would be the splash shield that goes over these N95s that aren't from America, that don't have the snug fit. But what we're doing is trying to give the layers of protection to protect healthcare workers with what we don't usually have. A little lesser protection underneath the face mask, goggles. We're adding layers of protection. We're trying to deal with it, is what I'm saying.
Yeah. Let's go to Morty, who has a question now. Morty, can you unmute yourself and ask your question?
My question is,
you have an echo. Unfortunately, we're gonna. You have a microphone in the room. Can you turn that off?
Mute yours.
Off?
You can't be muted.
Oh, it's okay now.
Okay.
Okay. Try again. Go on.
All right.
You still have an echo.
It's okay. It's okay. Let him just ask it in one go, and then it'll be fine.
All right.
The ventilator situation, how bad is it in Massachusetts?
Who wants to take that? Christine, do you want to take that?
I understand right now that we are okay, but we don't have many, and it's not going to take much to put us in a crisis situation. Right now, I actually understand they're going to put 2 patients to 1 ventilator, and that's acceptable for, like Kevin said, in a crisis situation. So we are seeing training being done by, for nurses, for example, respiratory therapists usually do this of ventilating training, and respiratory therapy is a specialty, and people are jumping in, and we're trying to cross-train. So to answer your question, ventilators are a must, and we are starting to see a cross-training and the need for them, but we are not to this moment over our heads to this moment in Massachusetts, okay?
We're going to go to Rizwan next. Go ahead and unmute yourself and ask your question.
Hi, everyone. I'm Rizwan, and I'm not a health worker, but I'm connected one way or the other to the medical system here in Massachusetts. And I have a question that is there any because I didn't hear about the announcement that Massachusetts will cancel the non-urgent, treatment and surgeries in hospitals. So my question from you all, Dr. Kavanagh and Dr. Stanford, that is it safe to continue treatment in those hospitals which did not announce, shut down the treatment and care for non-urgent, patients? So yeah, this is my question. Thank
Well,
you.
I'll answer first. In Kentucky, we have no emergency surgeries right now. That not only frees up staff, but it does protect patients from coming into the facility who may get exposed to COVID-19. And the exposure could not only be from a patient that has come in with it, but also from the healthcare worker, because as you know, PPEs are running short. They are rationing PPEs and masks in Kentucky with one per shift. And we're a state that hasn't even been hit with a number of cases. The staff is getting overworked. They're getting very stressed out. And we really need to get people focused on making sure they only use the healthcare system if they absolutely need it and staying safe. And one of the things I wanted to talk about also, if I can get a moment, is on getting groceries and going shopping and things like this. That certainly staying at home as much as possible is key, and trying only to get supplies at the most once a week. A number of large states are not on stay-at-home orders. The best way to not get the virus is not to be exposed to the virus. Myself, we get our groceries delivered. I put non-perishables in the garage. That's all we're ordering. Let them sit there 3 days, which is about the maximum length the virus survives, and then take them into the house. So I think that those type of strategies are also very important until we get through this peak and we get a healthcare system where if you get sick, they can take care of you. You need to realize that ventilator patients on COVID-19 stay on there for greater than a week. Sometimes 10 days or 2 weeks. It's much longer than the normal ventilator patient. That's one of the reasons why they're running out of ventilators. And plus, you still have patients that have the flu that require a ventilator. So this is on top of everything else. If you look at the death rate in Italy, which is approaching 10%, and Mike Pence said that we're about ready to mimic Italy. That's how they're basing their modeling on. Their 10% figure instead of the 1% figure is because they've outstripped their healthcare system. And so I think we need to be very careful trying to not outstrip it. We need to get the workers focused on patients and see what we can do to support the workers. It's a very, very difficult situation.
Thank you.
Someone else, you had an idea of someone else who had a question?
Yes, I think
okay.
Gary had a question about a DIY mask, and I think Jody also had a question, so maybe we can go with Gary first. Gary, are you there?
Yeah, I'm here. Hi. I might get glitchy, so I'll take the video.
Yeah.
I didn't have a question about that. I just wanted to put out information about that.
Gary, do you want, is there a link that you would like to share, or?
I think I put it on the chat.
Perfect. We will then distribute that.
People can read it on the chat, right?
I do have another piece though.
Yes, go ahead.
Yeah, it's about 3 or 4 messages ago. On another front, not to change the topic because this could go on endlessly, I imagine, because it's a big deal, and I feel incredibly angry and sad about what's happening with this conversation, or what's not getting, what the nurses aren't getting, and the healthcare professionals in the hospitals aren't getting. I'm not getting angry at the talk itself, but the material piece. On another front, I'm interested in what we could do. There's 2 prongs. There's the emotional support, and then there's a practical support. And I don't know that I have the organizational abilities to do this first piece, which is to organize to help these folks get deliveries or deliver food to the things they need in their daily life, so they're not doing their 12-hour shift totally wasted and tired, and coming home realizing, oh, I've got to take kid, I've got to get on the website. Maybe there are single moms out there or single dads out there. So there's a whole other piece that could be incredible. And I'm not so sure if anybody has ideas or knows of any information around that happening. That's the first one. And the second, should we do at a time, Sanford, or should I mention my piece around the website with the emotional
do that later.
support?
Yeah. Let's just ask,
Okay.
let's actually see if Christine has anything to say about support for nurses of the kind that you suggested. Do you have anything to add on that?
Well, we are educators first, primarily. We're nurse educators. So we do offer resiliency programs, and we're actually putting information online. We have flyers also posted online. So you bring this, the man who just spoke is a Gary, and he raises a really important issue. And we've attended to it. We've been teaching resiliency for a while, actually. I'm happy that we have done this prior to this crisis, so people have the resources. But if someone needs something now, they can go to our website and they can get, like I said, there's posted sheets, and we are having continuing education for our nurses online, so that they can go in at any time and not only serve their own emotional needs, but their time will be so limited, and they can receive continuing education also, credits at the same time.
Sanford, I think Jody had a really good point to make about, in terms of what Gary suggested, in terms of providing physical help.
Yeah, let's see if she wants to ask.
Professionals, yes.
Jody, do you want to ask your question? Yeah.
Hi. I mean, I had asked, what is it that lay people could do to help support healthcare workers? And I think that this thing that Gary raised is a good idea. And the first thing that I thought of is that we've had, at least in Western Massachusetts, we've had a lot of attention, both in like in our local paper here in the Valley and the Gazette, but also on our next door bulletin boards, which are very active in our communities, that there are mutual aid associations that are starting to form in a lot of communities. And I really wonder if those can be mobilized to include things like, groceries, et cetera, support for healthcare workers in particular. A lot of them are focused now on at-risk groups, elders, disabled folks, people with underlying conditions, and how to help them. But if there's a way that we can go out of our way to add supporting healthcare workers to those networks that are really just coming online now, that could be a really concrete thing.
All right, one of the things you have to be careful of, and this is what happened in Kentucky, is that early in the epidemic, before we knew how infectious this was, there was a push when we canceled schools to have delivery with the buses of the meals to the children of a lot of the inner city families, so that they would not, so they at least get one hot meal a day. Unfortunately, one of the bus drivers came down with COVID-19. He was, probably asymptomatically spreading it 2 days before. You also have asymptomatic carriage. So that when you do this, you really have to deliver it in a way that you can control for infectious spread. And this is very hard. Even the grocery delivery people and the people that are delivering out in front of, for example, Whole Foods or Walmart, they're becoming very concerned. They want to be first line food, they want to be first line responders, which I think they are and should be, and have adequate PPE. So until we can get a test that you can adequately tell whether or not a person is carrying the virus and spreading the virus or not, they do have one, but it's not available. Have one in 15 minutes and start to determine who's carrying it. You've got to be very careful that you don't set up a vector that then spreads the virus to all the healthcare workers. Or if you come in contact with the healthcare worker who is at a high risk of carrying the virus, that you do not pick it up. Healthcare workers are really the true heroes. When you look at fatality statistics, a lot of that can be based upon viral load that you're exposed to. They are repeatedly exposed to patients with this, with inadequate protection. Their viral load of exposure is going to be extremely high. Their chances of getting this disease and getting severe disease, even when they're young, is going to be there. So it's not as simple as with some of the infectious disease that if the person's not sick, everything's fine. That's not the case. Myself, and this just personally, I don't even go get takeout food anymore. I'm over 65, very high risk. I won't go up to a drive-in to even get takeout because I have no way of knowing that that person who is delivering the food or preparing the food has or has not COVID-19 or is a carrier. You just can't tell at this point. That's why I said the best way of approaching this epidemic for the public is to stay at home, have your food delivered. I get perishables or non-perishable foods that I can leave out for 3 days, and then at that time I bring it in. When they get a test out that we can do rapid testing on the workers, when the workers get PPEs, that's when you can start to, talk about some of these things. But believe me, to deliver your food to a healthcare worker has to be done very carefully. You, number one, have to make sure that you don't contaminate it, and you have to transfer it in such a way that you're not going to contaminate yourself. So there's a lot of things need to be considered with that.
Yes, thank you. I want to go back to Amy Geralaman, who has some other points to make on this. Amy, do you want to weigh in a little bit here further?
Sure. I saw that in New York City, one of the things that they were doing was that they were getting their nurses, especially since New York City is ground zero with this, they were giving them private transportation to the hospital, so they didn't have to take buses and trains anymore because they were just so concerned about infecting their families and being sick along the way. I think that that's something that could be done. I'm not sure what New York City's model is, but that's, to me, that makes sense. And I agree with the comments about you have to be careful about cross-contamination and infecting people. Perhaps the people that do this need to wear a mask, wear gloves. It's such a changeable situation, but this, where I live, we don't have good public transportation, but I know in the cities that this will be very important.
I'm noticing that we're at the hour, and we had planned this for an hour. I think we, our guests have been very kind to be with us, and I think that people still have a few more questions. So I think maybe we should take, a few more questions and then move towards wrapping up. What do you think, Melika?
I think that's great. I'm just wondering whether Dr. Kavanagh and Christine are okay for just a few more minutes so that we can accommodate a few more.
Yeah, I'm fine.
Yeah. Can I just say one thing about the volunteering? What I'm finding is there are people who would love some people to pick up PPE for them. For example, there are people that are spending thousands of dollars to protect themselves, and there are some that just can't afford it. So to the gal in the Western Mass, she wants to help. I agree with Kevin. Food may not be the best thing, but PPE, if it's in plastic and someone's got gloves, they can pick it up and help deliver it to somebody, or a drop-off center to organize some kind of donation center and drop-off. This is what the people, especially in home care, they really need personal protective equipment. And some people have it to offer. Mm-hmm.
Oh, so organize it with people who already have it, and maybe even people who would like to contribute to buying that. Where's PPE available right now for purchase, Christine?
Well, I won't say, I mean, I know you can get it on Amazon, but it's just they're gouging. So what I'm saying is sometimes people have it because they were healthcare people, they have it in their homes, they call us up. I know some people have said to me, we've got it at our house if you can pick it up. What I'm saying to the gal in Western Mass, if you could coordinate something like that.
Yeah, and I think purchasing is not a good idea because it drives up the price. If you want to donate money to get PPE, give it to the Massachusetts Nurses Association so they can try to do an en bloc purchase and get a better price. This is another reason why you need to have a national coordinated effort. And the thing that really got, I feel, the president and the national policymakers to shift is the pictures and what was happening on the ground in New York City. I mean, so getting out the word on what's happening is extremely important. because, as I said, you just don't have the staff right now to organize. They are all being busy, but getting out the word, making sure we have transparency, posting stories on Facebook, this is what will also be of great help. But the medical staff right now is 100% plus tied up at hospitals. And there is a lot of difficulty between the staff and the hospital administration. And one of the things that got us, for example, made us, at least me, quite upset is that we've had several CEOs, national CEOs, forgo their salaries in order to support their workers and to keep their companies going. Well, we had a hospital in Kentucky, because no elective surgery and they had a little down period, are furloughing workers. Well, that's no way to build your system to get ready. And so there is a huge amount of problems in the healthcare system that have to be addressed, but we need to do that possibly in June, not in the next 2 weeks, because we are in absolute crisis mode at this point.
Yeah.
I think that Annie has a question. I'm not sure whether Annie has audio, however. Annie, if you want to try to ask your question, you could try now.
Sanford, I'm showing up as two
Okay.
people.
There you go.
My
Yes.
audio is through one and my video is through another.
Okay, there you go. Okay.
There I am. Okay, so my question, I guess, is for either Christine or Dr. Kavanagh. We keep hearing about people who are asymptomatic and you know how they should quarantine themselves for 14 days. So I traveled exactly 2 weeks ago and have been self-isolated, haven't even hugged my kids for 2 weeks. They're happy about that. But if there are people who are going to remain asymptomatic, at what point can you feel like you're in the clear and you're not going to give it to somebody even though you are a carrier?
Who wants to speak to that?
Well,
Dr. Kavanagh?
Yeah, well, I mean, it's just not known. Certainly 2 weeks is the current guidance. At least that's what I've been hearing. And if you don't develop symptoms for 2 weeks after an exposure, you're assumed to be clear. But it would be nice to have a rapid test available or a home test in order to tell for sure. No one knows if there's what's called super spreaders. It'll just be spreading the virus. No one knows any of these questions. I mean, you can really dwell on this and think up of the worst and most horrible things, but 2 weeks seems to be pretty much the time period that you can rest fairly assured, and I know I'm hedging, that you don't have problems. What you do not want to do is to go in and get a test at a clinic. You'll take up a needed test from someone else, and then you'll probably expose yourself to the COVID-19 virus. So don't let this dwell on your mind. 2 weeks is good. Also, try to comfort yourself that in the group below 20, if they do get this virus, they tend to do by far the best. China reports that they've had, I don't think any fatalities, or maybe 1 or 2 in that group, extremely rare. Not saying you can't get sick, but that group tends to do the best. So if I went 14 days without symptoms, I would be pretty assured I didn't have an exposure. Now, if you had symptoms and you got sick, how long it takes for you to not shed the virus, I have not heard that. I was going to ask that on a CDC call today, and that's one of the questions I didn't get. I should also note that if you are living with someone with COVID-19, the CDC does have guidance posted on their website on how best to take care of your family member without getting infected. Of course, that's a high-risk situation, but there is guidance on their website, and I would check that because, again, that's probably going to change very, very often as we learn more and more about the virus.
Well, Melika, I think that maybe, I think you should go ahead and wrap up now.
Well, I would just like to thank everybody for joining us, and especially Dr. Kavanagh and Christine for their very valuable time, their very valuable insights. So much of these things we don't get from the CDC guidelines, and the kinds of information that they have given us is, I think, really, really helpful, and things that we can start implementing now. I would also encourage everyone to visit the Massachusetts Nurses Association website, because they have a list of all of the things that they're trying to do and engage with the state in order to get more support for our healthcare workers. So that's a really good resource. Also, in the chat section of our call, we have lots of our viewers have shared resources that we will sort of share with the wider community as well once we send out the recording of this event. I'd also like to thank Sanford for sort of facilitating this with me, and again, many thanks to Christine and Dr. Kavanagh.
Okay, thank you very much.
Thank you very much. It's very enjoyable. Thank you.